Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. Jaundice is the yellow discoloration that's caused by elevated bilirubin levels in the blood. We can see this discoloration on the skin, the sclera, and the mucous membranes. It typically follows a cephalocaudal pattern, so it starts at the head and works its way down. It's important to note that some jaundice is normal in newborns. Bilirubin levels increase in newborns because of increased breakdown of red blood cells. Neonatal red blood cells have a shorter lifespan, and as these red blood cells break down, they release bilirubin. Immature liver function is also a cause. The liver is responsible for conjugating the bilirubin to make it water soluble for excretion. Liver immaturity in newborns decreases the ability to conjugate bilirubin in the first few days after birth. Also, we have reduced bilirubin clearance. So feeding is important to reduce serum bilirubin levels because it stimulates peristalsis and produces more rapid passage of meconium, which is thus going to diminish the amount of reabsorption of unconjugated bilirubin. In addition to this, colostrum has a laxative effect as well. Risk factors for hyperbilirubinemia include prematurity, bruising or cephalohematoma, ABO or RH incompatibility, poor feeding and dehydration, polycythemia with a higher concentration of red blood cells that will be broken down, exclusive breastfeeding with poor intake or suboptimal feeding, sibling history of jaundice, and then Asian and Native Americans have a higher prevalence as well. So when we look at breastfeeding-related jaundice, breastfeeding jaundice can happen for an infant that is otherwise healthy. This is caused because of a lack of effective breastfeeding. If the baby isn't feeding effectively, we have a possibility of dehydration and then have less stooling. Colostrum has that laxative effect that can help with stooling and with excretion if we get the baby feeding. If the baby isn't stooling, we're going to have an increase of reabsorption of bilirubin. So the bilirubin can be reabsorbed from the intestine and then it will need to be conjugated again to be excreted. So newborns should be breastfeeding 8 to 12 times per day. We can also see breast milk jaundice. Breast milk jaundice begins around day 5 to 10 and can last up to 12 weeks, so it has a late onset. With this, the bilirubin levels will peak during the second week and then diminish. And with breast milk jaundice, there's no sign of liver dysfunction or hemolysis. Physiologic jaundice is a non-pathologic jaundice that occurs in up to 60% of term newborns. This can be normal, mild, and transient. It appears around 2 to 3 days of life, peaks at 3 to 5 days, and resolves within 2 weeks in full-term infants. So we're seeing it appear after 24 hours, peaking around 3 to 5 days, resolving in 1 to 2 weeks. This is usually harmless and resolves without treatment. Pathologic jaundice is the more concerning jaundice. Potential causes will be hemolysis, so things like the cephalohematomas that need to be broken down, that's going to release bilirubin. Bruising, releasing bilirubin. Things like erythroblastosis fetalis and significant anemia is going to cause more red blood cell production, and then those red blood cells are also going to be broken down, and all of this hemolysis is going to be the potential problem. Infection, blood incompatibility, or other hemolytic disease. So ABO incompatibility, RH incompatibility, also G6PD, these are all things that can cause a lot of hemolysis. Prematurity. With prematurity, we have a greater risk of having hyperbilirubinemia. We have higher volume of red blood cells that have short lifespans. And then we also have slow gut motility. So we run back into that same issue where the bilirubin is reabsorbed from the gut and back into the bloodstream. This is going to be concerning if it appears within the first 24 hours of life. Bilirubin levels that are rising rapidly. So not only are we looking at the level, but how quickly is it increasing, or we call it the rate of rise. If the bilirubin levels are becoming excessively high, so then we have more circulating unconjugated bilirubin, and this can cross the blood-brain barrier and cause neurologic damage. And this is going to persist longer than 2 weeks. So clinical signs that we can see: yellow discoloration of the skin and sclera progressing in that cephalocaudal direction from head down. Lethargy, poor feeding, hypotonia, high-pitched cry. These can all be signs of acute bilirubin encephalopathy, which are acute manifestations of bilirubin toxicity and can worsen to seizures, coma, and even death. So the concern would be developing kernicterus. And kernicterus is the severe brain damage that can happen. It's irreversible and has long-term consequence for bilirubin toxicity, including delayed motor skills, hearing loss, and cerebral palsy. So with this, we can see behavior changes, irritability or that high-pitched cry, lethargy, instability, so temperature instability or respiratory issues like apnea. Retrocallus. So retrocallus is an involuntary spasm of the neck muscles, and it forces the head to tilt backwards. And then we can also see abnormal tone like arching. Uncontrolled movements, bulging fontanelle due to an increase in intracranial pressure with toxic brain swelling. Infection signs can be a contributing factor, and then neurologic symptoms. So initially we see things like hypotonia, lethargy, poor startle reflex, poor suck, high-pitched cry. As it progresses after a few days, we start seeing more irritability and now muscle rigidity, twitching, seizures. Some infants may even die at this stage. So kernicterus is the neurologic syndrome caused by the deposit of the unconjugated bilirubin in the brain. And this can also lead to cerebral palsy as well. For evaluation, we can look at the bilirubin level by using either the transcutaneous bilirubin screening, where we use an instrument that touches the baby's skin and gives a readout of the estimated bilirubin level, or with a total serum bilirubin with a blood test. We can look at the baby's blood type and then also check Coombs or DAT testing. And this is going to show if the mother's antibodies are on the baby's red blood cells. If this is the case, the antibodies can break the red blood cells down, which will release more bilirubin and increase the baby's bilirubin levels. We can look at the reticulocyte count to get an indicator of if there are a lot of these being released. That's an indication of hemolysis. And then we're going to use our specific nomograms to really look at what the bilirubin level is in relation to the actual number of hours of life that the baby is. The main treatment for this is going to be phototherapy. Phototherapy will change the unconjugated bilirubin to conjugated bilirubin, which will be water soluble for excretion. We want to have eye protection for the baby if we're using phototherapy, and we should have them just in a diaper so that as much skin is exposed as possible. When a baby's using phototherapy, we're going to be monitoring hydration and we're going to be monitoring temperature. So we can use the lights, we call them the Billy lights, or there's also a Billy blanket that wraps around, and that's going to have the same effect. We want to promote frequent feedings, and lactation support if she's breastfeeding, because the more the baby's eating, the more the baby's stooling to help with excretion. And then we can consider exchange transfusions in severe cases, especially with like RH incompatibility. If we do an exchange transfusion, they actually remove some of the baby's blood in small amounts and they replace it with compatible blood. So to review, jaundice is the yellow discoloration of skin, sclera, and mucous membranes caused by elevated levels of bilirubin. This is caused by immature liver function, increased breakdown of red blood cells, and reduced bilirubin clearance. Physiologic jaundice occurs in 60% of newborns and resolves without treatment. Pathologic jaundice, the bilirubin levels will rise quickly, they can cross the blood-brain barrier, and can lead to permanent neurologic damage. The number one priority is going to be to reduce circulating unconjugated bilirubin. So we need to identify risk factors, frequent assessment of bilirubin levels and symptoms, frequent feeding, phototherapy, and exchange transfusions if indicated. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.